But now to you, Denmark, to Mads Koch Hansen, which is the chair of the Danish Medical Association, and he will discuss the dialogue because one of big data in Denmark. Please.
Thank you very much for being able to be in here and speak in Iceland. Then I have seen snow this winter. We haven't had nearly no snow in Denmark, so I had to go to Austria to see snow. And thank you very much. It's a very hot topic in Denmark as well. We have had some development of this area over the last year. And actually yesterday I spent the whole day discussing the handle of big data in Denmark, because we have gathered all the information, as I will tell you in a moment. And as Robert just said, we are on the area of a new era because of all these data. And it's not only health data, it's also data about the social status and all that you can gather, and you can take, because of the power of the computers, you can take so many things into consideration if you just ask the right questions to these units. So we are talking about big data, and big data is a term which comes from computing, because it's the way we handle a huge amount of data, and we can use that term on the health data as well now. And from a patient's point of view, there will be some benefits, but when we do research, it will be enormous what we can do with this, because we can see patterns that would not be able to see in any other way, because we have so many data gathered together, and you will not be able to see these incidents if you just sat and looked and diagrams and so on. So the computer have so much more power to look over big amounts of data. What is happening in Denmark is that the government in 2012 decided to gather all these health databases in one institution. And we have a lot of databases. For instance, the abortion register, the cancer register, the death certificate register, the diabetes register, information about IVF deformations, register about birth and vaccinations, and together with all the prescriptions for the last many years, you can gather actually a very good picture, not only for a person, but for a whole population. And all these registers was gathered in one institution called the Statens Serum Institute, was used to produce the vaccines in Denmark. That don't produce vaccines any longer, but they still have research, and they have all this information, and together with all these registers, they put in the biobank of all the Danish. It's a virtual biobank because it gathers all the biobanks, so if you need information and you don't know where it is, you can ask in this virtual biobank, and they'll gather it for you or point you in the right direction. So you will be able to get all this information about one person or population, and you will be able to analyze biobank material as well, if you have, of course, the right authorization to do so. When they performed this change, there was not much discussion about it. I think it was a good way to go forward, but what is important is, as Robert just said, is who is actually going to have access, how are we going to protect this information, how are we going to use this information, because it would be unethical not to use all this information for patients if we can do better treatment, or if we can prevent more people from getting sick. We have to use information, so that's the good part of it. But we won't make it open for everybody to go into it, and the researchers should be able to go there and get the help to get all the information out. So all that stuff we have been participating in as a medical association in Denmark, because they came out with some suggestion for the rules of how to manage the whole system in September last year. And what they sent out there as a suggestion, which was actually going to be the way that they would do it, it was very scary, because they haven't done all these thinking about protection of the individual. How do we actually secure that the people and the health professionals would think this is a good idea? Because if they were talking a lot about how do we get private companies accessing this information in producing new medication and other things. And that is, of course, important, but that must not be the only purpose of doing this whole thing, because then we will miss the good things. So the Medical Association in Denmark got into this debate, and for the first time ever, I think, we talked the authorities to withdraw the suggestion they have just made, because it was so filled with errors, so it could not be fixed. It had to be rewritten. And some other organizations, both patient organization and research societies, said almost the same thing. And within a month, they have performed a kind of board for the whole organization, and we have got a place in this board. And yesterday we was having our second meeting and starting to take all these discussions together with the authorities to make it be of benefits for the people, for the health professionals, for the society, and not only for the companies. So there was a very strict political agenda that they wanted Denmark to be one of the leading nations in using data for research, and that's a good thing. But if you only look at research as companies buying access to health information, it's not the way we're going to make it happen. Because, as Robert also said, we need to have security of how they manage the information, and if we as health professionals do not have this security, we won't put the data into the system, and somehow we will block it, and the patient won't go to the doctor and say, I have problems, because if they know that these problems are getting sold to as knowledge to somebody else, they won't be coming to the doctor, and the whole doctor-patient relationship will break down. So this agenda is still on in Denmark. We are short of workplaces, and we have to do new thinking to make workplaces in Denmark. So we have a unique possibility of using data because the changes that have been made. The question is also, who owns this data? Is it the government who owns the data, or is it the health professionals who put the data in, or is it the patients who own them? Because it's their information. So we want to take this discussion in Denmark, and when we find out who owns the data, who can give access to the data, who can allow you to access the data. They have skipped these questions until now. What we have in Denmark, as we just talked about, we have a social security number, which was established in '68, and every citizen in Denmark have a unique number of 10 numbers, mainly made out of the birthday, and then added 4 other numbers. This is unique, and there is a mathematic rule, so you cannot create a new number without having it run through a computer. It has to be created in a certain way. And the only thing you can see when you see my security number, you can see 2 things. You can see my date of birth, which would be the 6th of November '68, and then you can see which gender I was when I was born. We have a discussion in Denmark these days about if you are able to change your gender, if you feel you're not the right gender and so on. And that's difficult, very difficult in Denmark, because then this whole system will break down. If it's 1, 3, 5, 7 or 9 at the end, you will be a boy, or if it's 2, 4, 6, 8, and 0. It would be a girl, and you do not have a 0 for nothing. So it's a little different. But we have these numbers, and this is unique. Every time you approach authorities, you'll be asked for your social security number, and they will know everything about you. I can look up, as Joan just did. We have a homepage where I can look up every information that the government, not every, but almost every information that the government has on my social security number. I cannot see anybody else. I can see a little about my wife and my children, but for me, I can see what they have registered. And of course, the authorities have everything. You name it, they have it. So, and because of this number and unique number, it's very easy to gather biobank material and health information, and it's easy to get knowledge out of all these data. What we haven't done yet is to have it in a way that is easy to access for researchers, because it's very different kind of data sets that is in this computer or in this institution now. But I don't think we should make the data sets the same, but the computers are able now to get information out of every kind of data set and gather them. So this is a good thing if you are a health professional, you have a patient coming in emergency room. If the ambulance personnel are able to identify the patient, we can look up his health record before he's arriving. We can see what medication he has been prescribed, and actually bought at the pharmacy, what health record is, and so on, so we can be prepared. But as you can understand, it's very frightening to think about what you can do if you have no good intentions with using this information. And there is problems with that, but Robert have just that area. We have some breakdowns in security. We have seen just recently in Denmark, a pharmaceutical company wanted to find, I think it was about 5,000 people worldwide for some research. And they pull in an application for the State Institute to get the information about 200 people in Denmark, because they only need 200 in Denmark. But what they read in the letter, they read 5,000, so they provided the company with identities of 8,000 people. And their health records were sent to this company. And then the company, of course, was very happy, because that was a little more than they expected. But they wrote some letters to some people to ask them if they wanted to participate in this research. They knew from the authorities that you have a cardiovascular disease, and we are doing some research. Do you want to participate? And some people said, "Oh, that's good. I want to participate." But one of these people they wrote to was a doctor, who said, "How in the world do they know that? I haven't told this company that I had a cardiovascular disease, and how do they know it?" So he wanted to find out. And then, in that way, we became aware of that they have been sending us no, it was not 80,000 people that they had the health records from, and that was questioned in the news, of course, and it was something was gone completely wrong, and they didn't know. So it wasn't. It was just an example of what can go wrong in this area. Just last week, I think it was in the UK, they had a similar, or not a similar, because this was intended. They had an insurance company that wanted to know a little bit about the people living in Britain. And in England, they have gathered all the information as well. So they have health records for about 60 million Brits in one area now. And this company just bought health information for 75 million people. Not for research, of course. Insurance companies do not do research. They do insurance, and it's much easier for them now to calculate what prices people should pay, of course. And this was intended, as I understood the newspaper I was reading, because they have bought the information from this data, and this is what we really do not want. This is the worst example of things that can happen with all this information gathered together. So it is happening, and we must see to that the patients and the health professionals are confident that this not happen, that this would not be happening in the future. So what is special about the health data? Because when I'm traveling to the United States, then they need to know so much about me, and I have to give my fingerprints for 10 fingers and a picture and everything, and I deliver all of it to the States, and they can do it with it what they want, because I cannot get into the States if they don't have it. And I know I do it, and they will be gathering all information about me together with all the other stuff they gather about me. But that is intended, and I know they are doing it. But the difference is when you go to the doctor and have a problem, you're not suspecting these problems to be shared with anybody. The confidentiality in the room between the patient and the doctor is very important, because you have to believe that the doctor is doing the best for you, of course, and you have to have confidence in the doctor's way of handling information about you, because if you do not have this confidence, you won't tell him anything, and the doctor can help you. It just was this week, we have a new research done in Denmark. They have talked to thousands of people about who do you trust, your doctor and your dentist and your car salesman and journalists and politicians and so on. And like every other time, doctors are in the very top of this list. People have very much confidentiality in the doctor. And I was asked if that made me happy, and I said, of course, as the president of the Medical Association, this makes me happy, but it cannot be in any other way. Because if you do not have this confidence in the doctor role, how could you go and share your worries with him? So it must be like this, and therefore doctors have this. We must take this role on us also to be able to fight for the safety of all this information that we gather about patients, and we have to be very active in that. And that's why this work group is so important, because it will help doctors all over the world actually to be able to do this. So, and when we talk about data, there's a lot of different kinds of data. Some of them are we can easily find out who the person is. It's identifiable because the name is on the paper, and so it's, of course, we know who we're talking about. But a lot of data is collected for quality improvement, and we have there's no persons. It's just data about how we perform, and we do not need to know the persons behind all the data. We have research data. They are very often identifiable as well, but of course there are different kinds of research and so on. And what is new in the era of big data is that we can gather all this information together and draw knowledge out of every kind of data. So we should realize that these different kinds of data sets different rules for us to how to handle them. When data are identifiable, we must seek to have an informed consent for patients, for the use, for the storage, and for the secondary use of data, as we have wrote down in the Helsinki Declaration and so on. But data collected for health improvement or quality improvement do not necessarily have the same obligations for us to be sure that it's different kind of data sets. I think it's very important in the discussion to be aware of these kind of data sets, how we get them, and when we are obliged to have the informed consent. About the ethics, I think the confidentiality is the key word, because patient data must be treated according to the principles of confidentiality overall. And informed consent, we must have, we must give information about who is accessing your data if it is your personalized data. I can look all my health records up on the internet with a delay for 2 weeks. Everything will be put on the internet. I can go in with a log-on to see my health records from hospitals and private doctors and prescriptions and so on. But I can also see who else is accessing my data, because every doctor in Denmark is able to access the data. But if I do not have this patient into treatment, I have no right to see the patient's data. So the patients can see who is accessing my data and what have the authorities gathered about me. And I think it's very important also to have this possibility to actually look over who is accessing my data. It's not if you are in hospital, you will be in a hospital, and people in the hospital will have there's another log-on system, so the hospital can see who is accessing the data sets, but the individual cannot see who is accessing while I'm in hospital. But once I'm out of hospital, they can see whoever looks up the data. What we worry about is safe storage, because all the storage we hear about unattended or attended but not right access to data, we must be assured that we have to that we are doing everything to let that happen. The Helsinki Declaration I have mentioned about the informed consent, and the challenge is with the big data issue to see the common good in having these data and using the data for better health, provide better healthcare for the people. But there should be a payback to the people about the knowledge should be out known and used if we're using the data for research and so on. Yeah, and there is a discussion about is it just the modern technology that actually provides us with new ethical problems, or is it the same problems that we have always had, but it's just at a bigger scale now because of the possibility of going into the data in another way. And about research, just a few words. It's very important to withhold the things from the Helsinki Declaration, but on the other hand, it should be easy for researchers to access data, to get knowledge out of data, because we have, I think we must do that for the patients. We must seek bigger knowledge and in healthcare, and then we have this not only a right, but we must do it. So it's important to prevent the trust of the patients on the handling of data. We must protect ourselves against these stories from the UK and from Denmark where data slip out in the wrong way. As doctors, we have to get a lot of focus on this area. We must be there and protect the patients, not from themselves, but from the wrong use of the data of the patients. And we must see that there is an easy but monitored access for researchers to the data. So, thank you very much.
Thank you very much, Mads. I would just ask Maria to come and to put in her slide. Okay. Any questions for Mads?
you very much for an interesting perspective from the Danish experience. I wonder, I'd like to ask you about your personal opinion of the current collection at Statens Serum Institute. Do you think that just the current state of things, with all of these databases identifiable at Statens Serum Institute, that collection in and of itself is goes against the new Helsinki Declaration? And if you don't think so, what would be your logic in saying that such a large identifiable database can be collected and stored as it is now?
A lot of the data is not identifiable, so it's data that just about the quality of the system.
The birth register and the cancer register,
yes,
all of those registers, they're
yes,
all identifiable.
The Helsinki Declaration, I think, is have mentioned if it's by the law that you should give this information, you should not give you the informed consent for the data to be collected. So you cannot get out of these registers because it's by the law that every time you have a vaccination, you have to be registered so we can see who have this vaccinations and so on.
So national law supersedes the Helsinki Declaration, in your opinion?
Yes, in some instances.
Well, be careful with that.
Yeah.
I would say no, because we expressly say in the Declaration of Helsinki that a national law should not break the declaration.
Yes.
So that is very important now. But here's a difference. If you have a register, for instance, of who has been vaccinated, that itself is not a research purpose.
That's why.
Here comes the next question: is there being a secondary use of that? And for that, the Declaration of Helsinki says, if there is a secondary use, then you have to ask the people, can we use this data for this secondary use, and give an informed consent on that?
Yes.
Now, that sometimes may not be possible, or may be absolutely impractical, which we have to acknowledge that is the case, and still there may be something worthwhile to look for. And for that purpose, the Declaration of Helsinki asks for a governance solution, which says there has to be an ethics committee, which then gives a substitute decision. Basically, it gives the informed consent to that.
Presumed consent.
No, it's not a presumed consent. No. Actually not. No, it's not a presumed consent. It is a substitute for the informed consent. It is something completely different than a presumed consent. This is very important to understand this, that this is not a presumed consent. So what we do here is really that there has to be, first of all, the task to find an informed consent by the person, him or herself, whenever possible. If that is not possible, then there is the governance solution, which would be the ethics committee, which then says yes to that research purpose.
Yes, we have that structure. So there is an ethical governance over.
So the message that I take from this is that you can gather the data in a huge database, identifiable, without the consent of the individual, but then for the actual research purpose, that's the step where you start seeking the...
Yes. Yes.
Is that...
Yes. The key word is this is not gathered for research, this is gathered for registration. So,
yes.
So when you do research, it's another thing,
So the final question then would be, if you move the data from Statens Serum Institute to the researcher as unidentifiable data, when you remove the 5 things that we heard about that might identify you as a person, does that relieve you from the informed consent or the substitute of informed consent?
We have to,
basically.
If you can identify the data by the CPR numbers, for instance, then we have to have the informed consent, but not if it is research on registers, because then you can have data that are identifiable, but you use them in another way, and the researchers have to fill in an obligation to have this information, and they have to go to an ethics committee to have it approved before they, and there are laws about who can get access and so on, who have to be fulfilled before you can get access to the databases.
Yeah, thank you. And I'm Dr. Ishii from Japan Medical Association, and I was a member of the working group for Declaration of Helsinki. And we finalized it, And so that we need a new working group for the database. So your question is so good, but we need a solution for that. So we get assembled here. And I have one question for you. And speaking about the social security number related with the health database, with just one unit in Denmark, or in Japan we are speaking about the separated.
Yes.
How
We have this unit for the health data, and we have another unit for every other data we have in Denmark, which is called the Danish statistics, where you can ask them anything about any Dane or about a population. But the health data is gathered in the State Assembly Institute because this is special data. So there is a collaboration between the two, but we haven't joined them all in one institution. And I think it is because somehow the authorities know that these informations are special. So, and they have combined it with the biobank. That was one of the issues what they did in the 2012 when they came all together. But of course, this is if you have wrong intentions, you have a lot of knowledge here.
Yes. Before we make it clear, let me ask, when you drive and exceed the speed of limit, and you're going somewhere, and in the office, and your security number is put on, and your health data will be introduced from this security number at that office.
My health data not in an office.
That's impossible.
Yeah.
Okay.
You have to be in a health institution, a hospital, to access it.
Sorry to say, but I know that there are a lot of interest and questions, and